Ontario, like the other provinces in the country, has adopted a 4-month interval between doses to get as many first shots into as many arms as possible and to hopefully slow the spread of the variants notably and avoid the third wave. Ontario's already into it, and much of the country is facing a third wave. But this has been a big point of discussion on our program and elsewhere between and among medical experts, that time interval between doses. The clinical evidence in clinical trials was 21 days between Pfizer-BioNTech, 28 days for the Moderna vaccine between first and second doses, and then it was expanded, led by Quebec, up to 4 months, 16 weeks. Canada's National Advisory Committee on Immunization allowed that or recommended that 3 weeks ago. But as we were reporting yesterday, revising its guidance, and we expect new details perhaps within the next week or two on what that time interval should be for certain parts of the Canadian population. All of that by way of background to a conversation we're going to have now about this interval, concerns about it, and a Canadian compromise for it. You know them both well from our program and elsewhere. Dr. Isaac Bogoch is a member of Ontario's COVID-19 task force. Dr. David Naylor is the co-chair of Canada's federal force, the COVID-19 Immunity Task Force. And they have today written an op-ed piece in the Globe and Mail that caught our attention and will likely catch yours too, again, because of the questions they raise and the solution they propose. Gentlemen, I can't tell you how good it is to have both of you on our program. Thank you very much.
My pleasure.
So, Dr. Bogoch, let me start with you because I'll tell you what caught my interest, number one. I just introduced you both by your official titles as far as vaccine rollout goes in this country, very highly placed provincially and federally. But at the top of this op-ed, you've both said you are doctors at University of Toronto. Why did you do that?
Well, for starters, we both are doctors at the University of Toronto. I think it's a fair statement.
Stops
exactly.
Right there.
Exactly. I mean, I don't think it's fair to say that we're going to be representing the views of the organizations that we represent or the task forces we're sitting on. We know that data emerges and data changes. And of course, everybody needs to process that data, and task force have methods of coming to a consensus for recommendations. So by no means would I say that I'm going to represent the task force that I sit on and say that that's a unanimous opinion or that's a consensus opinion. But I certainly, as a physician, as a scientist, and based out of the University of Toronto, I've looked at a lot of the data available, and I think that it's a very reasonable thing to do. I like the plan that NACI had to really spread apart doses, to really ensure we vaccinate a significant proportion of the population as fast as possible. But of course, things change, and since those recommendations, there's been some evidence emerging that perhaps that's not the best approach in all people.
Can I pause you right there because I want to talk about concerns? So it's clearly you're speaking as doctors, not in any sort of, as I said, vaccine task force capacity, but still very, very interesting. Dr. Naylor, to you, what was it? Was there a moment? Was there a decision? Was there something that brought the two of you together to feel that you had to address it in this way by writing an opinion piece today?
Thanks very much, Heather. I was concerned out of the gate about where NACI had gone. I thought, exactly as Dr. Bogoch has said, that it was a very smart direction to go, but it was the 4-month spread that I thought was a little beyond where the evidence had taken us thus far. I noted that they said up to 4-month spreads were recommended, but it was pretty, I think, predictable that there would be a view that that was actually the guideline. In Quebec, it was 90 days, by the way. So we weren't really at the full 16 weeks. And I think Quebec has actually stayed there, Heather, which is interesting. So my view out of the gate was that this was a little bit undifferentiated. And actually, the next morning I wrote to Isaac and others saying I wasn't sure that this was the best way forward and some stratification would be smart. And I haven't changed my view.
Okay. Sorry about that. Yeah, thank you for that correct number from Quebec. Quebec leading on all of that. But now, as we're all aware, NACI is now saying the guidance up to 16 weeks between the first and second doses to get as many shots into as many Canadian arms as possible. You call it a first doses fast approach or strategy. But even stronger than how you just put it, Dr. Naylor, coming back to you, Dr. Bogoch, is if I can bring up a line from the piece, there's no data on 16-week waits. There's no data on 16-week waits. What are your concerns then about this, Dr. Bogoch?
Well, I mean, for starters, I certainly agree with Nassi on that delayed second dose. I mean, it totally makes sense. And if we were asking this question in December, the question was, can we extend dose 2 from dose 1? And the answer was, well, we're not really sure. But after that, the question is, okay, it looks like we can extend the time between dose 2 and dose 1. And the real question was, okay, how long can we extend that second dose? How long can we delay that second dose to get as many needles in arms, which I completely agree is the right approach. And the answer is, if you really scratch the surface and look for data, you will see some good data for 2 months. You'll certainly see some reasonable data for 3 months. And 4 months, it's just hard to find good data to support that duration. Having said that, it doesn't make it wrong. It just means that we don't have the data to support that.
Was that just an arbitrary number? I mean, how did the 16 weeks even come out?
Well, I'm not going to speak on Nassi's behalf, but it certainly does allow to get the vast majority of Canadians vaccinated over a short period of time. But it looks like I'm speaking over Dr. Naylor, so I'll let him answer that one.
You looked like you wanted to say, I'm sorry. Back to you, Dr. Naylor. Your thoughts on that? Was it just an arbitrary number?
No, it wasn't arbitrary. When I first addressed it on CBC, actually, the evening before it was released, the report wasn't out. You can actually see exactly what Nassi has done. A fantastic group. They've been doing this since 1964, so it's not as though this institution is new and doesn't have a machinery to give us good ideas. They had modeled this pretty carefully, Heather. The view was it looked good out to 3 months for AstraZeneca. They had two months data in hand, as Dr. Bogoch has said. The question was, how far could you go to cover 80% of the population in a reasonably timely fashion? So they were modeling the entire population and making a call as to how to get us to 80% coverage. And the 4-month spread worked in that way. It was all carefully modeled. I think, as Isaac has said, it's definitely the right direction. I felt that way all along.
But you're calling now for something, someone on our program or on CBC News yesterday used the word nuanced and you used stratification. So Dr. Naylor, what is it now within, if that blanket 16 weeks or four months now, what do you think is the Canadian compromise? What should we be doing instead?
I think we have to start figuring out the groups that may actually be at greater risk. As I said earlier, again, publicly, the immunocompromised are concerned. People have had transplants, maybe on immunosuppressive drugs. We also have to think about the seniors. It's not clear what the exact cutoff would be, but certainly we know this virus hits the elderly with what's been an exponential risk. So many of the deaths have been in that group. So many of the ICU admissions to serious diseases in that group. So the concept here is simply let's pay special attention to the delays and shorten them where we can for these individuals who are at risk. It's just a way of making sure we are not only achieving the bigger goal of covering the population and breaking the back of this epidemic, this third wave, but also not having groups that wait unduly and are at risk. It's just an important variant, if you will.
Yes.
A variant.
Variant's the key word. Let me quote again from the piece that you've written. Again, that doesn't require a one-size-fits-all solution. There's room for a clinical perspective that shortens the vaccine dose interval for the highest risk individuals and subgroups while still adhering to a public health perspective of greatest good for the greatest number. The clinical perspective, again, Dr. Bogoch writing this, the two of you as doctors, the clinical perspective, do you feel it's being lost in this discussion?
Well, like anything else, I think data clearly changes with time. And over the last little while, we have seen emerging data where certain individuals, like, as Dr. Naylor points out, perhaps people that are immunocompromised or people on the older end of the spectrum, they don't mount the same immune response. So the risk from a clinical standpoint is, if you've given them one dose of the vaccine, are they prone to infection with that longer 4-month duration? between dose 1 and dose 2. And of course, as Dr. Naylor pointed out, we know that clinically there are certain groups that just do worse. They're overrepresented in hospitalizations, they're overrepresented in the ICU, they're overrepresented in deaths. You can't ignore it. You've got to take it seriously, and you've got to protect the most vulnerable. So from where that Venn diagram of public health and clinical medicine overlap, we've got to be very careful here. And perhaps that one-size-fits-all solution isn't ideal. And we could find that sweet spot where we have the right groups. Of course, operationalizing this is another thing too, right? Where this is a countrywide public health program that's implemented at the level of the provinces. So you've got to find good ways of doing this. Defining the age, defining what constitutes a compromised immune system. Of course, it can be done and operationalized, but that does take some thought. But yeah, shortening that 4-month duration between doses looks like it's an increasingly good idea for those cohorts.
I guess, again, coming back to that, we have a vaccine supply issue. We have provinces who are in charge of their own regimes. And with all of this, you're saying allowing for that individual nuance to who best can receive a shortened dose schedule. And then coming back to the clinical perspective. So who would you like to see playing a role that isn't currently now playing a role, or to the degree you'd like to see them playing a role, Dr. Naylor?
So by playing a role, do you mean decision-making or individuals who are given a shorter duration?
No, I think we were clear on who gets the shorter duration in terms of the decision-making.
Decision-making is clearly a provincial jurisdiction on this front.
But is this family doctor you'd like to see more involved in, or?
So I will say generally, I think in many provinces, we've underused family doctors. I'd like to see family doctors more involved in Ontario as well, frankly, because they are in a position to help with this kind of stratification. But as Dr. Bogoch said, you have to keep it simple. You need some general guidelines, and that's where you can use the family doctor's good judgment to help you implement this. If we make it complicated, Heather, I think then we're into a sort of fine graining where we'll spend more time arguing about who should get earlier jabs than we will delivering them. And that has to be avoided. And we've said pretty clearly in the final paragraph of this piece, keep it simple. Let's not lose the plot here. We've got to keep moving fast to stay ahead of this third wave. But let's just give this a little bit of wiggle room for those who are most at risk and keep an eye on the evidence. This could all change, and I would emphasize, as Dr. Bogoch has said, some of this is driven by new evidence. The evidence isn't clinical evidence. That's so important to say. The last thing I'd add, Heather, is the debate has been noisy. We've had people being very aggressive based on, say, antibody testing. We have to go right back to those 3 and 4 week spreads for the mRNA vaccines. The last thing this country needs right now is a noisy, aggressive debate between scientists and medics about how exactly this should be spread out. Let's find a compromise that satisfies the clinical and public health imperatives, and let's get back to work putting needles in arms instead of debating this and eroding vaccine confidence at a critical time in this country's epidemic history.
Gentlemen, thank you. I really appreciate your time this morning, both of you, Dr. Isaac Bogoch, Dr. David Naylor, with me this morning.